Topic for the presentation is Electronic Apex Locators. This presentation comes from the Department of Conservative Dentistry, Anu Dental College, Muatuvara. So the contents of this talk goes like this. First we will say what is a working length, and the next we will move on to the different terminologies that are there in a root apex. Then we will move on to the generations of apex locators, the common problems associated with apex locators, working with, conclusion and references. So what is a working length? The working length can be defined as a distance from the coronal reference point. It can be an incisal edge for an anterior teeth. It can be a cusp tip for a posterior teeth. Okay, so from the coronal reference point to the point where the canal preparation and finally the obturation should terminate. Moving on to the terminologies at the root apex. First we will see what is an anatomic apex. So anatomic apex is the tip and end of the root which is determined morphologically. So when you extract the teeth and what you see at the apex is the anatomic apex. Radiographic apex is the tip or the end of the root that is determined radiographically. And apical foramen is the main apical opening of the root canal. Okay, so it is normally funnel shaped and it is frequently eccentrically located away from the anatomic apex or the radiographic apex. Next we will see what is an apical constriction, which is also called as a minor diameter, which is nothing but the apical portion of the root canal having the narrowest diameter. Okay. This minor diameter widens apically into the apical foramen. Okay. So that apical foramen is also called as a major diameter, and this assumes a funnel shape. Moving on to cemento-dentinal junction. So it is a region, there's one cemento-dentinal junction in the coronal third of the root, and now we will see what is there at the apex. So it is a region where the cementum and dentin are united. This CDJ does not coincide with the apical constriction. It is 0.5 to 0.3 mm short of the anatomic apex. So this is the diagrammatic representation of the root apex. You can see an apical constriction here, also called as a minor diameter, which is the narrowest portion of the root canal. This minor diameter widens out into the apical foramen, okay, also called as a major diameter. And you have the cemento-dentinal junction. And when you take an X-ray, the apex what you see is called as the radiographic apex. Okay, and you have to make a note that all these doesn't coincide. CDJ is different, apical constriction or the minor diameter is a different, and major diameter is a different location. So ideally, the working length is measured up to the apical constriction, also called as the minor diameter. So what happens if the working length becomes too long? It is going to damage the periodontium and then in alveolar bone and the cementum. If it is too short, you are not able to completely remove the remnants from the root. Okay, and so what happens? The healing at the periapical area becomes incomplete. And let's see, how do we determine a working length? This working length for determination, we require a file or a reamer, and this file or a reamer will have a silicone rubber stopper, okay, which is used as a stop attachment. And if you look properly, some of these rubber stoppers, you also have circular rubber stopper and you also have tear shaped teardrop shaped rubber stopper. So the advantage of a teardrop shaped rubber stopper is you can align it based on the curvature of the root canal. Okay, so probably if it is a curved root canal, you can pre-curve your stainless steel instrument, the file or the reamer, and the teardrop attachment can be aligned in such a way whether it can be at the inner portion of the curve or the outer portion of the curve. And then you should know what is a coronal reference point, which is cavo incisal for a anterior teeth and cavo occlusal for a posterior teeth. So if you look into this picture, you see the coronal reference point. Okay. So in the first picture, you will find the coronal reference point. It is not a stable reference point. Okay. This is an unsupported enamel. So when a patient bites on anything hard, this is going to fracture. So the coronal reference point should be a stable reference point and it should be repeatable during the appointments. So all this unsupported enamel has to be removed so that you get a stable coronal reference point. So the same holds good for a molar teeth as well. So now we will look into the different methods of determining your working length. This working length determination can be broadly classified as radiographic and non-radiographic method. So under radiographic methods, you have 10 different types. The most commonly used is the Ingles method. Okay. And non-radiographic method, you have apex finder, audiometric method, tactile method, paper point evaluation method, and electronic apex locator. This presentation will be on the electronics apex locator. The electronic apex locator is used for determining the working length and it is an adjunct to the radiography. That means you cannot rely on this electronic apex locator fully. You have to take a radiograph and confirm the obturation or the master cone x-ray before you do your obturation. So they locate the apical constriction or the cemento-dentinal junction or the apical foramen and not the radiographic apex. Okay. So if you look into this picture, you will find that this cemento-dentinal junction is 0.5 mm short of the anatomic root apex. So we moving on to the different generations of electronic apex locator. The first generation apex locator, they are nothing but resistance based instrument. Okay, so an example of, you have multiple types. One such example is the Sono Explorer. It measures opposition to the flow of a direct current. This is a very old type of apex locator. The procedure is like this. You have a lip clip which is attached to the corner of the lip and the file is attached to a holder. Okay, this holder should be plastic and a metal handle will require an insulation. Then the file is slowly inserted into the canal. When it reaches the apex, you will hear a beep sound. Okay, so that shows you have reached the apical terminal point. Okay, that's how. So the moment you hear the beep sound, you will not further insert the file into the canal. So it works on the principle that the resistance of the oral mucous membrane and the apical tissue is the same. That is, it is around 6.5 kiloohms. So this is how the schematic representation goes, and so this is the file which is inserted into the canal. Okay, and once this oral mucous once the file touches the apex, okay, it is going to match the resistance of the oral mucous membrane, and that's how you determine the working length. The common problems which we face with the first generation are the canal should be totally dry. that there should not be any blood or tissue fluid or electrolytes such as sodium hypochlorite, saline, or any type of restoration. Okay, and you require a lip clip to complete the circuit, and this contact has to be really good. Then later on, to overcome the defects of the first generation, came the second generation Apex Locator. This is a impedance based instrument. Okay, that is, it measures opposition to the flow of alternating current. An example of it is the Endocator. So this type generation Apex Locator works on the principle that root canal is considered as a hollow tube. Okay. And when you look properly, the dentine thickness is not uniform. It is thicker at the coronal portion, and as you reach the cemento-dentinal junction at the apex, it is thinner. So there is an electrical impedance, okay, as you insert the file into the canal, okay, and this impedance, there is a sharp decrease at the cemento-dentinal junction. This sudden drop in the electrical impedance is measured electrically. There is no lip clip in the second generation and the probes are insulated. The disadvantage of the second generation are it works poorly in young patient. Okay, that is in young tooth. Okay, the transparent dentine develops late. You will not have a proper apical constriction, or the cemento-dentinal junction may not be that prominent in an young patient. So this generation could not be used in an young patient. And the insulation is very bulky. This prevents insertion in curved canals. It is more complicated type of instrument, and similarly like the first generation, the presence of electrolytes in the root canal causes inaccuracy. Then came the third generation Apex Locator. Okay. This is nothing but a frequency dependent machine or a comparative impedance. First generation is resistance type, second generation is impedance type, the third generation is comparative impedance. Okay, we will look into the principle of the third generation Apex Locators works on the principle that we use two type of current. One is a high frequency current, the other one is a low frequency current, and the sides in the canal give differences in impedance between the two frequencies. Okay. So when in a tissue through which when you pass two ACs of different frequencies, the low frequency current will impede more than the high frequency current. The impedance will change depending on the location of the canal. Procedure is there is a lip clip and to be used like how we do it in a first generation. The file is slowly inserted into the canal. The coronal portion of the canal gives a minimal difference, okay, between the impedance value between the two frequency. And as the file goes deeper into the canal and when it reaches the CDJ, okay, this difference is going to be maximum, and that's how you recognize the apex. The advantage of the third generation is it can be used in wet canals too. It is easy to use. It uses a K file and it has got an audible indication, like how you see in the first generation you will have a beep sound once you reach the apical terminus. The disadvantage of third generation is the presence of gutta perca will act as an insulator. It requires a lip clip and there are chances of short circuit. Moving on to the fourth generation Apex Locator, it measures resistance and capacitance separately rather than the impedance value like how it is done in a third generation. This is a more recent type of Apex Locator, and examples are the Rave Apex 4 and AFA Apex Finder. So there can be different combination values of capacitance and resistance that provide the same impedance and the same foraminal reading. An example of this type is the APA Apex Finder. The advantages, it has got better accuracy. Disadvantages, they tend to perform better in dry canals, and generally all Apex Locator, it is better to go in for a dry canal. The fifth generation is a dual frequency ratio type Apex Locator. Okay, so what they do is they compare the data from an electrical characteristics of the canal, and they had some mathematical calculation along with it, okay, to obtain the apex. Okay. Hence it has got, so that is the something a calculation based type of apex locator, mathematical calculation type of apex locator. The details, the exact details of how it functions is not revealed by the company. They say that it has got better accuracy in both dry and the wet canals, and examples of this are the Propex 2 and Propex Pixie. So this is a Propex Pixie. The advantage, it is too handy. You can it is very small and it can be used with ease in general practice. The sixth generation is the adaptive apex locator, and they say you don't have to dry the canal in this particular type of generation. It is Apex 6. See, this is the apex locator. Okay, there's a lip clip. What you see here is a file holder. Moving on to the combination of apex locator and endodontic handpiece. That is, in one system itself, you have both, which function as both as an apex locator as well as an endodontic handpiece to prepare the root canal. One such example is the Tri-Auto ZX. It is the cordless electric endodontic handpiece with a built-in root ZX apex locator. Basically, you have three safety mechanism in this type of machine. One is a auto start stop mechanism. Next is a auto torque reverse mechanism. Next is a auto apical reverse mechanism. Let's see what is an auto start stop mechanism. Here the handpiece starts rotation when the instrument enters the canal, and when the instrument is removed from the canal, the handpiece stops automatically. Auto torque reverse mechanism is the handpiece will stop rotating once it reaches the torque threshold. That is, once it increases the value of 30 grams per centimeter square, this handpiece will stop rotating. The advantage of this auto torque reverse mechanism is this will prevent instrument breakage. When it exceeds this value, and if the handpiece continues to rotate, the instrument is going to fracture. Next is a auto apical reverse mechanism. It stops and reverses the rotation when the instrument tip reaches the apical constriction taken from the working length. So you have three inbuilt mechanisms in the same machine. One is auto start stop, auto torque, and auto apical reverse mechanism. Let's see what are the common problems which we come across with an apex locator. A presence of a phenomena like inflammation will affect the accuracy of the apex locator. And when you have a metallic restoration, that is when you have an old amalgam restoration in the cavity, this restoration has to be completely removed. Otherwise, it can create short circuit. Next is the canal patency. The canal should be completely patent and it should not have any dentinal debris in the root canal. This will disrupt the electrical resistance between the canal and the periodontal ligament. Next is the immature or the blunderbuss apex. That is, when you, especially we saw that in a blunderbuss canal, the dentine thickness is not uniform. You have, the dentine, you will not have a proper apical constriction in a blunderbuss canal. So it tends to give a wrong reading. And some apex locator will interfere with cardiac pacemakers. The recent ones will not have such issues. Next is the medical legal issue. You cannot rely on an apex locator completely, because when you take a radiograph and you have a pre and a post-op radiograph, in case of a medical legal cases, you will have a record, whereas if it is an apex locator, you cannot have a record. So these are the common problems which we face with an apex locators. Next, we will see the uses of apex locator. It is understood, it helps in easy location of the apex, and it can detect root perforations, and it can diagnose root fracture. And as we saw earlier, some function as both ended on electric handpiece and apex locator, and some function even as a vitality testing machine as well. And there are also combination of apex locators and ultrasonics. These are the different applications of apex locators. Moving on to another small terminology called as a working width. Working width is defined as the initial and post instrumentation horizontal dimension of the root canal system at the working length as well as at the different working length. So initial width will not be the same as that of the final width. So why should we know about the working width? What is the significance of a working width? So sometimes we say we want a round apical stop. Okay, what are the advantage with a round apical stop? So when you have a round apical stop, it is easier to achieve a three-dimensional impermeable seal, because the round shape will conform to the round cross-sectional tip of the guttapercha. When you have a large working width of the apical area, the problem is, the advantage is it removes more, you will be able to clean the periapical area more easily, but the problem is you will not get a proper stop. So both has got its own advantages and disadvantages. Now we will move on to the advantages of a narrow apex and a broad apex. Advantage of a narrow apex is it decreases the risk of canal transportation. It avoids extrusion of the debris and the obturating material. Disadvantages are there will be incomplete removal of the infected dentine. It is not ideal for a lateral compaction, and the irrigants may not reach the apical third of the root canal. Advantage of a wide apex are you can completely remove the infected dentine and clean the periapical area, so it provides better disinfection of the apical third. Disadvantages are there are more chances for extrusion of the irrigants and the obturating material. It is not recommended for thermoplastic obturation. More chances for preparation errors. So to conclude, a precise location of the apex is mandatory for the success of an endodontic treatment, whether being a round apex or a large apex. So it is always better not to rely on endodontic apex locator as it is. You should have a radiograph to eliminate the errors in working length determination. So these are my references. Thank you.